Hi, everyone. I'm thrilled to be here on social media with Dr. Maryam Motlagh, the CEO of MyoAligner, the inventor of MyoAligner, and our newest member of the AHS faculty. So welcome, Dr. Motlagh. How are you today?
Very good. Excited to be here on this Friday morning. We've seen a lot of each other lately. It's
I know,
exciting.
it's funny you say that because this is, a very casual conversation. But we've gotten so many inquiries and so much buzz about, the current interviews that you were on with Dr. DeLuke, our last conversation that we did impromptu on Wednesday. And there's just so much mystery out there. I think there's two mysteries. One is why good dentistry still fails, which we'll talk about from your perception. And then also just like what is myoaligner and how does that fit into your regimen of good comprehensive care? So I think let's first off start out by just introducing yourself because some people may not know you. They may not have seen the interviews yet, and just a casual. I'm not going to do a formal interview,
Okay.
a formal bio on this platform. So go ahead and just tell us a little bit about your story and let's get to know you a little bit better.
Sure. I've been practicing as a general dentist for about 25 years. When I graduated, I was very excited about all the smile makeovers, it's extreme makeovers and cosmetic dentistry was really hot about 20 years ago. So I started doing a lot of smile makeover, introduced myself as a cosmetic dentist. And I was also a TMJ patient myself, so I was really interested in learning more about TMD and the connection with occlusion and airway. So I kind of like followed, I emphasize a lot of my postdoctorate studies on that. I started taking SPEAR seminars, learned more about CR philosophy. I joined the International College of Craniomandibular Orthopedics and LBI and learned more about a neuromuscular aspect of dentistry and basically combine these. And later on, I was introduced to Dr. Dave Singh, and I got to know his philosophy with airway expansion and pneumopedics and expansion that can improve airway. So with my restorative background and then now airway and all of that, there was different techniques that I learned. And in the process, I just tried to, that's just my nature. I liked simple things, simple solutions to a complex problem. Even when I cook in my kitchen, everything is organized. I know
Right,
where
right.
to go.
Mm-hmm.
I always tell
Yep.
my son, a good chef is an organized chef because when you have
Right.
things
It's not much
planned,
different, right?
it's not, yes, it's just like cooking. But in cooking, you can follow a recipe step by step. In dentistry, it's very different. Yes, we need to have a background understanding, but every patient is different. We customize every treatment for a patient, especially when you look at a person as a whole. It's and when they are suffering from functional issues, posture, breathing issues, it's really a multifaceted issue. So it's not a easy recipe to follow. And at the end of the day, our diagnosis is a comprehensive understanding of what's going on with the patient. And that really establishes long-term success. I was seeing some of my own cases, some of my colleagues' cases that were beautiful restorations by healing, not because the crown margins were open and not because we left decay behind, because patients were breaking these restorations, similar to why they broke their own teeth. So that's why I took more of a physiologic approach. I'm honored to have received my mastership from International College of Craniomandibular Orthopedics. I published, I have a peer review publication that's available to you. And I also went through FDA and tried to make this treatment that we are offering legit and safe for the patients. Going through regulations teaches you a lot. So that's why I got MyoLiner FDA cleared and for migraine headaches and TMJ treatment. So bridging the gap between medicine and dentistry. And when we have things like that, then we can communicate with our doctors better so they understand the impact of oral function and oral health on their patient's whole health. So that's my ultimate goal. I love to teach. I love to empower other dentists. So that's why we are doing through Myeliner and through collaboration with Airway Health Solution, because your dentists are in the mindset that they like to offer the comprehensive approach. They have good understanding of airway. They're doing airway orthodontics. So I like to bring more of an airway focused restorative to them and make their treatments last longer.
Well, we certainly appreciate you sharing your knowledge and you're inventing the solution. It's really remarkable. And the FDA approval, I know, is not easy. So you didn't take any shortcuts, and we all appreciate that. I am curious, when you say you're bridging the gap, why do you think the gap exists? Like, why do we allow for beautiful dentistry to fail? Why is this an afterthought after it failed rather than preventing it from happening in the first place?
I think some of it is politics and some of it is our educational system that was set up on that. 40, 50 years ago, they tried to separate dentistry from medicine. So they could put a limit to how much dental coverage would cover, $1,000, $1,500. That has not changed in the past 50 years, while everything else has gone up in price. So they really limited the practice of dentistry to just fixing a few teeth and doing some cleaning. What dentistry covers these days is basically, with $1,000, you get maybe a partial coverage on a crown and a couple cleanings, and you cannot offer a comprehensive approach to patients. But a lot of their dental problems is affecting medical. So with us proving that there is a big connection between medical and dental, we've had full mouth reconstructions covered by the VA because they saw the impact of the size and ratio of the teeth and how this patient was functioning with a correct occlusion compared to extremely worn down, broken teeth. So the doctors are trying to understand. And once we bridge that gap, medical will cover more. So it will be to the patient's advantage. And it would be easier for providers to offer comprehensive care and deliver comprehensive care because money is not an issue. So, and then the second factor, I think, is the educational system, based on 4 years of undergrad and then 4 years of in dentistry. There's not much emphasis. Yes, we get training on how to do beautiful restorations, DO, MOD, MODL, do maybe root canals, not much on orthodontics, which is really a great foundation for any dentistry, correct occlusal alignment. So there's still a disconnect, at dental schools. And for some reason, some groups are just refusing to admit the connection between airway and oral health. And so, but we're trying to change it, and we can change it by doing more cases. There's thousands of successful cases between me and my other colleagues who are doing what's best for their patient, rather than just being stuck with the mainstream. And that's the freedom that we have as practitioners. We can expand our knowledge and offer the ultimate treatment to our patient, and not have our hands tied with what their insurance covers, because insurance is not to their best interest usually.
Correct. So let's see some of these patients. I mean, I love seeing is believing. Let's see some of the work the standard of care that you wish to see. I think it's amazing that you were able to build these solutions for complex problems. And I know you can't imagine ever going backwards, right?
No, once you see it, you cannot unsee it. That's what all my colleagues say. Once you see the impact of this solution, the long-term impacts of looking at a whole picture rather than just doing single tooth dentistry, you can see that. So that's why we picked this topic, why beautiful dentistry fails. And what we're trying to do is to really simplify complex cases by taking an airway-centered and physiologic approach to dentistry. So look at the picture on the left. You can see 4 worn down, extremely worn down, traumatized anterior teeth. And then the lab technician is trying to build one single veneer to a tooth that has probably cracked or is symptomatic. That's what we do in dentistry, in general dentistry every day. Without looking at the wear pattern on the rest of the teeth and why we're here, and why that tooth broke. So my objective is for our listeners to understand the intimate connection between airway, TMD, and occlusion, and just that position of the mandible, the size of the maxilla, how it can limit tongue space. These patients, air always wins. So these patients are trying to open up their airway. And if you go back Monday morning and look at your patient's wear pattern, when they have a big overjet and the incisal edges of their upper and lower teeth don't even mesh together, but there's severe wear on that. That's not because they're chewing on rocks, because they're trying to open up their airway. And just grab a mirror and have the patient look at their wear pattern and duplicate that wear pattern. Have them bring their jaw forward until those incisal edges mesh. And you can see a big gap in the posteriors opening up, and you can see a lot of tongue space. So ask the patient, why do you think you're doing this? And you say, I don't know, so it's usually that protrusive pattern. It's usually trying to open up their airway. That's why we make mandibular advancement devices, to hold their jaw in that position. So these patients, their wear pattern can show that. Their TMJ pain can really show that. Why are patients getting compression pain here? Why are they getting ear problems? Because their condyle has retracted back. And why is the condyle doing that? Just because the teeth are meshing together in that position. Every time you swallow, go ahead and do that right now. What happens? You close your mouth and the teeth slightly touch and the tongue presses against something. Hopefully it's pressing against the roof of your mouth. Sometimes it's on the sides because there's no room for the tongue, and that's why they get scalloping. So looking at the TMD, noise and pain, feeling the muscles. Why are these muscles in spasm? They should be addressed because we're not chewing 24/7. We're only chewing maybe a couple of hours a day maximum total. So if these teeth are not meshing together, why do these patients have pain? So identifying when you understand these signs and symptoms, and there's a list of signs that patient can relate to you, or symptoms that you see in the mouth, from scalloping, from small airway, from abfractions. Abfractions are not because patients are brushing too hard. That's because of the flexion of the teeth at the gum line, because the forces are not down the occlusal long axis. So there's a lot of signs for us. If we know what to look for, a hygienist, a myofunctional therapist, a dentist, dental assistant, they can see that and start the conversation with patient for a more whole health approach, not just trying to fix a single tooth that broke or is chipping. Teeth, our enamel is the hardest structure in our body. It's harder than our bones. So if the patient is wearing down and breaking that hard structure, they're going to break your porcelain if it's in their way of breathing and functioning. So identifying the right candidates, will really help the dentist offer the right solution to them. Or if the patient refuses to do more of a comprehensive dentistry, at least they know, they're aware of it, and they plan on it. They might not do it this year, but in 2 years they might be able to save enough money to be able to offer a more comprehensive solution. And my goal is yes, go ahead.
I was going to say, is it ever too late? Like, for instance, say the beautiful dentistry fails, the patient comes back. Like, what do you recommend the dentist does at that time, or the dental hygienist? What did they say to their patients at those times? I mean, it's such a difficult conversation. Can you maybe comment on that?
Actually, when it fails, it's better if the dentist had that conversation with the patient, because then, the patient understands why it was important that it was brought up. That reminds me of a story that I want to share. My son is 21 now. When I was pregnant, I went on a leave while I had a general dentist cover for me at the office. So what happened is that shortly before I went on my maternity leave, I had a patient that had extremely worn down front teeth. He was in his probably late 60s, and he had almost like 20, all 4 lower incisors extremely worn down. So he asked me to veneer those. And I said, this is a pathological occlusion. You're banging on those teeth because you're trying to open your airway. I would rather not do any dentistry on these and just leave them alone because they're going to last you. As soon as I start cutting on these, I have to shave them down. It can change your bite, and I just don't feel comfortable doing that. So I refused to do this, to offer 4 veneers to him, which could have been several $1,000s. I said I would rather not do it and see it fail. So I go on maternity leave, and the general dentist that was covering me, she didn't know much about airway and things like that. So, just common sense, she went ahead and veneered those. And by the time I came back from my maternity leave, they had broken at the gum line.
Mm, mm.
So at that point, the patient told me, it's like, you told me so, and I didn't take your advice.
Right,
But,
right. I
you
told you
know,
so, right?
so we ended up doing, and I'm hoping to maybe share his picture in a bit longer
Oh,
course that
great.
we have. Yeah.
Okay.
Yeah. So after that, he called me a gourmet dentist, like gourmet food. He called me a
Oh,
gourmet
that is,
dentist.
I like that, a gourmet dentist. I like that. That's sticky for sure.
And he was in his late 60s. He went for a full
Mhm.
mouth reconstruction. I ended up
Wow.
opening his bite because he was completely collapsed. He had a vertical of maybe 8 or 9 millimeters, just the
Hmm.
height of his front teeth. I opened him, and when you open and change the posture of the mandible and maxilla to a good position, airway opens up, they function. He felt better. And, it really impacts lives. You're going beyond just a beautiful smile, and you're really helping with these patients' overall health. So, my point is that it's better to have that conversation before your dentistry fails.
Hmm.
And that only comes from knowing what to look for and understanding the signs and symptoms and notifying the patient of what you find. At the end of the day, we talk to the patient about procedures, alternative risk with each procedure, and any questions that they might have. So it's our duty as providers to offer several options of treatment to our patients, including no treatment. And then it's up to them to decide what's best for them at that point in time. And they might decide to go with single tooth dentistry and not address the big picture, but at least they know, they're aware, you've done your job as a provider, and then they can come back when they're ready.
Another difficult, perhaps, conversation is, let's say you've taken this training now and then you go back and same patient 6 months later as a hygienist or the doctor, all of a sudden you're recommending something new and they may ask you, well, why haven't you mentioned this before? How do you handle a conversation like that? Or how do you coach the doctors you work with to handle those type of questions?
That's a great question. And I always, still today, even though I teach thousands of dentists, still today, I tell my patients that I'm taking continuing education to learn more. So
Mhm.
you can tell the patient that we just took some continuing education. There's some new techniques that we're learning, and we are doing that so we can add our services and help our patients. I didn't know this before. So I use that. Don't be shy. We don't know everything. Don't be shy to
Mhm.
have that honest conversation with your patients. Say, last year I didn't know. When I originally did mouth reconstructions 20 years ago, I never put them in I just put them in a retainer. These days, because I know more about airway, I just put them in a mat device. So a mat
Mm.
device is my retainer, just in case if they have they have congestion and they have a bad night and their airway is closed, they're not grinding and chipping the edge of my veneers. So, and these patients that come back from like 20 years ago and I haven't done that, then I offer them something new. Patients, I think they appreciate that you're constantly learning,
I
and
agree.
not just sticking with what you graduated from dental school 20, 30 years ago.
And also kind of that lead in line, like, well, what we know today can help kind of bridge that gap too. I find as a hygienist, that was also always a helpful phrase, what we know today. There
Yes,
is
I
a
mean, for
question
example,
in, yeah, go ahead.
As
Let's
a
just,
hygienist, for example, 30 years ago, you didn't offer laser treatment, cauterizing that
correct.
pocket. But you
Mhm.
do that now because once you get the training and the technology is available there, you can say, instead of putting medication there now, I can just laser that tissue for you and decontaminate the pocket for better treatment. So we're always learning and the patients appreciate it. Unfortunately, not always their insurance, dental insurance is to their benefit. And I know a lot of dentists, sometimes they withhold, they don't share the optimal treatment with patient because they make the decision that the patient cannot afford it. You never know, you need to, your objective should be to give the patient a wide range of options. At the end of the day, it's up to them. Who knows? Maybe they have family members that can help them achieve the optimal results. So don't be shy to discuss the optimal options with patients. But first, it comes from education. Education is everything, and so maybe we can address the question now.
Yeah, well, one of the questions, and we can address it after as well, is how it's a very broad question. So, how airway affects the whole body as such, like neck pain or posture changes. Can you kind of simplify such a complex question?
Very easy, very
Yes.
easy. How does the neck alignment and posture change? Look at me as I'm talking. My airway is almost open. My voice is good. If as soon as I start taking my jaw back, it's closing my airway. So if I had a deep bite with a retracted mandible, my airway would be compromised. But as soon as I tip my head forward, my airway opens. So there you go. This is postural adaptation. So if a patient that has a really deep bite and a retracted mandible, which we see a lot of times with our narrow maxillas, the jaw is retracted. That means 4 or 5 thousand times a day when they just swallow their saliva, their jaw has to go back. Muscle memory builds up there, and it will, because they have to function back there. The muscle cannot relax all the way in the optimal physiologic rest position that we learn at dental school and then go back here. So muscle memory is the big deal, and the muscles of the mandible learn to posture right there and hold that mandible ready to contact with the maxilla through the occlusion. So because they have that posture in their masticatory muscles, they have to tip the head forward. So that's how it affects posture. Also, canting of the jaw. If the lower jaw is canted to one side, let's say somebody has a bicuspid or drop off more on one side than the other, or they have a crossbite, their mandible is going to be canted. When the mandible is canted, it can affect the sphenoid bone alignment. It can affect shoulder alignment, C2, C1, C2 alignment, all the way down to their hips. So one of the things that I use in my office during my examination is an aqualizer. If you don't know what it is, look it up. Aqualizer. So it's just a water-filled bag. I think that was a great invention, and it allows for the body to kind of like settle into more of a physiologic position. So in my first examination, I have the patients bite down and I kind of like look at their eye alignment, shoulder alignment, and hip alignment. We have a postural grid in our office. And then I can put the alkalizer in their mouth, not as a therapeutic, but more as a diagnostic tool, and have them walk around. And because it's a water-filled bag, if they have more compression of the joint on one side, that water will fill more on that side because of osmosis, and it will level their bite, level their mandible. And immediately, within 5 minutes, you see their shoulder alignment and hip alignment. This is something that I learned from my mentor, Dr. Ira Shapiro, who unfortunately passed away we lost him a couple of months ago. He taught us so much about the connection between occlusion and posture. And there's references of that in my research. There's some citations of the connection between posture. And that's why for athletes, a lot of times they go for optimal bite alignment because they know they can improve their muscle recruitment and performance. There's been a lot of studies on that. So I hope that answered the question about posture.
That does. Thank you. That's a very, and also I always, as a hygienist, say it's not very attractive to get that double chin, but do it yourself. Put your jaw back and try to talk and see how it feels. Like you really want to just go forward in that natural forward head posture. So it's a nice exercise to do with your team.
It's great for our physical therapists to know. It's good for our chiropractors to know. So if they have a patient that's not healed, I have had patients for 6 months in physical therapy and they still have upper traps that are so tight and they're SCM. Why? Because air always wins. We'll do anything to open our airway so those patients are not going to really have total resolution unless their occlusion is taken care of. So integrating and understanding this physiologic workflow is what I really like to share with my colleagues, because that saved me from doing a lot of restorations over and over again, a lot of failures. There was more predictability, patients felt better, and it just overall improved my practice success. Mechanical dentistry is very limited. All of us were, as I mentioned, in dental school, we're taught to be tooth mechanics, and fix a tooth, put a beautiful crown on with a perfectly sealed margins, do a beautiful root canal. I think even endodontists need to understand the impact of airway. How many times do they get root canals to that has to be done over and over and over again? Sometimes it's not infection in the tooth. Sometimes it's that periodontal ligament that is highly populated by the trigeminal nerve that is being squeezed every time this patient is chewing and functioning. So that triggers pain, and then it can be misread as endodontic problem. So patients get root canals over and over again, and finally the root cracks, and they have to get a root canal, extraction and implant. So looking at the function, even for an endodontist, can be very important, not just the general dentist. So that increases the risk of complications, when there's excessive wear on the tooth, when there's abfractions, and the restorations will fail too. And how many times have you seen crowns break at the gum line on natural teeth, not even root canal teeth, but the crown is still intact? That's a function problem. And patient symptoms, again, for that root canal tooth that is not getting better, or sometimes you just put a little DO on number 15, and then the patient comes back and says, my jaw's popping and clicking after that. Why? That DO could be slightly high, so that can even change the path of the closure of the mandible for that patient. If I have a big rock in my shoe and I have to walk with that, I will adapt my foot so it doesn't put too much pressure on one spot, and I can still function. Same with a DO. If you put a high restoration in the mouth, the patient will adapt to live with it. But for that adaptation, they have to change the alignment of their jaw and maybe chew in a different pattern that's not triggering TMJ pain, muscle spasm, and all of that. So if you see that patients are complaining of TMD pain, they had some pre-existing pain that was, again, not brought up, so they blame it on you. So looking at the exam, again, I emphasize on the exam, it's very important to do that. So, as dentists, we like to transform smiles. We like to see, to do a lot of cosmetic dentistry. I think every single dentist, general dentist will call themselves a cosmetic dentist. Yes, that's great. As long as you don't have to change the function, as long as the teeth are just stained, you can do beautiful whitening, or you can put veneers on that does not change their alignment and function. It has to be exactly the same anatomy of their existing teeth. So if these patients are showing no sign of breakdown, if it's just for the tooth color, yes, your smile makers will last because you're just adapting to their natural teeth. But when there's a pathological occlusion, when present, that's a whole different ballgame, because these patients suffer from failing restorations. They have missing teeth. They have damaged or misaligned teeth. They have some TMD symptoms, some obstructive sleep apnea. They're functioning differently. So when you're seeing breakdown on the teeth and you're trying to change the structure of the bite, that's a different ballgame, and you need to look at all the contributing factors. And with restorative goals is not just a pretty smile anymore, but to improve this patient's function and give them longevity. So this doesn't not only just boost their smile confidence, but also it can boost their health. As you can see in this patient's face, you can see faces changing. You can see their eyes are brighter because these patients can breathe better. They can function better. They don't look as tired. So you're really changing lives when you do whole health dentistry. So more of a physiologic approach to dentistry, to full mouth reconstruction comes from doing more of a bite rehabilitation. When we are talking about a bite rehab, or we are talking about 6 veneers or 12 veneers to improve the shape, the height of the smile, we are in a different position. We not only need to improve aesthetics, but we need to make sure that we can enhance chewing and speaking. We can optimize the function of the muscles. We can improve the orthopedics of the head and neck, because the alignment of the head and neck will really change the alignment of the bite. You can all test that by just sitting upright and then biting down your teeth to see where the teeth mesh. For most people, if they're sitting upright, it's even bite on the posterior teeth. Now, if you have your teeth apart and just tip your head forward and gently bring your mandible up, you'll see that the front teeth are not meshing. Or tipping your head this way, and you can see that more on the left side is hitting. So if you're taking your impressions and you're establishing your bite in a completely reclined position for the patient, when they sit upright, they're going to have a completely different bite. So you really need to look at their posture, look at their neck alignment. So if I have a patient with spasm that has shoulders off and neck is swayed to one side, because the axis of rotation of the mouth actually from C2, not from the condyle, and it can really change their bite alignment. Years ago, I had a patient that I had done a beautiful full mouth reconstruction on. She went back to her general dentist for regular maintenance, and then the dentist, like after a few, sent her back to me, as he said, nothing on the right side is meeting now. And she came, yes, yeah, no, none of her molars were meeting on the right side. Most dentists would have just taken a articulating tape, tap, 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 let me grind the other side, or they would have built the other side. Instead of that, I just put my handpiece down and started talking to her to see what happened. And in our conversation, I realized that she had a ski accident. She had a concussion and she was a skier. And that's probably because her neck went out of alignment. So I didn't touch anything. I sent her to my upper cervical chiropractor, even though her teeth were not meshing. She had the neck aligned, and then everything came back to normal. And it's not rocket science. It's what you just practiced. By changing the posture of your neck, you are really changing the bite alignment. And I didn't shave anything down, and the bite alignment was just perfect.
It's the last bullet that you have there, but maximize longevity. I mean, it's such the benefit. Everyone's talking about your health span, versus your lifespan. And I think it's just such an important piece to the puzzle that I'm so glad you're bringing this to light.
Thank you. And it's all about really careful diagnosis and case selection and planning. Preparation meets opportunity equals success. You have to be prepared, and you have to talk to the patient about what you are seeing as a provider. What are the signs that you see? What are some of the symptoms that could be linked? Patient doesn't know that their itching ear or tinnitus can be related to TMD, but as a provider, so you need to bring that up. And so when patients, to my surprise, they get it. They understand the connection better than some of our providers, because they're not stuck with the old school of thinking and thinking of occlusion as a mechanical thing on an articulator. They understand that their muscles play an important role. And if you just do little things for them, just like I just shared, by changing posture, by using an oculizer to see how their body adapted to that occlusal alignment right away, it's just really opening for them. And they become your team players, and they can, so they don't set their expectations too high. They understand that there's some functional issues. They understand that they play an important role in longevity of this treatment, and it becomes more of a team approach than you just providing dentistry for them to see if it lasts or not.
Well, I'm excited to see some of these cases.
Oh, yes.
Yeah.
So this is one of my patients. Just look at the face. This is a full mouth reconstruction, but if you look at the face, it really goes beyond her. Yes, I gave her a beautiful smile, and but actually we had an interview with her on TV, and she came to the local TV and talked about her experience. She said the smile is just an added benefit that I didn't even ask for. She came to me. You can see pain in her face. You can see how her neck is completely swayed to one
Mm-hmm.
side. So
Mm-hmm.
she came to me for relief from TMD, from muscle pain. And when I looked at her mouth, I offered full mouth reconstruction. You can see she's not even smiling. A lot of these
Mm-hmm.
patients are just don't have the confidence to smile in their pre-op photos. But you can see their face has just more glow to them because they're out of pain. Living with chronic pain is really difficult. We only have a certain amount of energy to spend on thinking, on metabolism, on functioning during the day. And if we're burning half of that on dealing with pain, we just don't have enough energy left to function
Mm-hmm.
in our optimally. So these patients are constantly compensate because they're trying to adapt to a poor posture, to pain. And they feel much better once you give them not only the smile, but also open their airway. Hormones balance. They can sleep better, and we know that their sleep is essential for having balanced hormones. So bite rehabilitation can actually improve a woman's health besides just a smile makeover. I go back to comprehensive exam because it's very important. So when you have a patient, I think every patient should get a good assessment of their jaw joints. You know, if there's any noise, if there's limited range of motion, sometimes there's no noise and patients tell you, oh, I had noise, but it's gone now, but you can't even put your mirror in their mouth. That's even more advanced stages of TMD because now that the disc is completely out of alignment, it's not even reducing anymore. So understanding the role of the joints, I highly recommend that you examine TMD at every exam. The chance of oral cancer is only 1% of the population ends up with oral cancer, but all of us general dentists check for oral cancer at every single appointment and document it. The chance of people with TMD sitting in your chair is 30% in adults and 11% in children. 30% of adults, that's 600 patients in your practice if you have an average practice with 2,000 active patients. So that's a lot of patients that, you know, can be in your practice and have TMD issues, but you're not seeing it. And if you're jumping between patients and you have like 5 minutes for the exam, yes, you're just going to find a few cavities and go on. But if you just take a little bit more time, maybe 20 minutes with your exams, then you can check their jaw joints. You can look at their airway. You can just look at the back of their throat and see if their uvula is touching the base of the tongue or not. If you can see a nice arch, Malampati scores, you know, if you can visually see that, if you can see scalloping of their tongue, if you can see linea alba, you can see that these patients are really struggling with every swallow. So comprehensive exam is very important. I check all of that and it just becomes routine. When I start my exams, I actually start by rubbing my patient's shoulders and they all say, oh, that's good. Just continue on.
Right, right.
You know, I want to see what their traps are doing. So I just put my hands right there and just feel their traps. And I do feel a lot of popping. So if that's the case, then I know they have forward head posture. Then I start to go and feel their SCM, just rub my hands up and down from the base of their ear down to their neck and feel their SCMs, feel their temporalis, have them bite down and chew and clench so I can see if they're clenchers, or sometimes just putting my finger up in the joint and feeling their lateral pterygoids and medial pterygoids under their mandibles. So if you just do that, it just takes a few minutes and patient will, first of all, most dentists don't do that. So now it just puts you in a different category that you're looking for more things and you're having a more of a comprehensive approach beyond just their cavities. And then you can, you know, check the muscles, joint, airway, and bring up the conversation. You don't have to take up your hygienist exam. You know, I know you only have 10, 15 minutes, but you can bring up what you see and invite the patient to come back for another half an hour or 1 hour that you can do more of a comprehensive exam. You can say, I've taken some new courses. I've learned to go look beyond your mouth for a more whole health approach. And patients love that. These days, people are into optimal health. And I like to offer you another exam. You don't even have to charge for that, or just charge them a limited exam and come back and look at TMD. Most offices that do a head and neck exam, they charge around $350 to $400 for that exam. It's called comprehensive TMD exam, and we have a code for that that you can actually bill to medical, or patients can pay for that and then reimburse it through a super bill. So please don't be shy to offer a comprehensive exam for these patients. Postural analysis, I mentioned that earlier. It's very important. So if you're seeing that your patients are standing like that, and just them walking down your hallway, you can look at that. And if you have a posture grid, you can get them to stand in front of that posture grid. That would be great. So you can kind of like assess how this patient is going to respond to your comprehensive treatment. And also, trigeminal nerve, that's the most important thing in our head and neck, I think. The trigeminal nerve with its branches to the maxillary and mandibular branches, with its sensory and motor branches, plays an important role in our health, in our function, in our pain level. And one thing that we teach through our courses is how to tap into that trigeminal nerve and actually stimulate the nerve to get optimal muscle relaxations. So, lateral pterygoid, medial pterygoid, those are the muscles that are very painful to relax if you're using pressure and palpation. I know some chiropractors do that. Some physical therapists actually glove up and try to massage and release those muscles. Usually brings tears to their eyes. But there's instrumentation called TENS, ultra low frequency TENS. That is under 2 hertz, not something that you can buy on Amazon. They have been FDA cleared for specifically this reason, to stimulate that nerve and provide ultimate relaxation, usually within 40 minutes to an hour. So that can just set the foundation for you to start your construction bite. It's a starting point for you because you have achieved true physiologic rest position, regardless of where that pathological position is. Does that make sense?
Absolutely.
So usually when we treat a TMD patient or an airway patient, especially with TMD patients, it starts with a splint. So this is actually one of my full mouth reconstruction patients. Actually, this is the one that had the ski accident. So, but I don't have her. But yeah,
it all comes back.
Yes. So you can see she has a narrow upper lower jaw. She has worn down teeth. So I used to start with an orthotic. Basically, I found her physiologic position, and there's different techniques. Some doctors use a leaf gauge. Some use a phonetic bite. There's different techniques that you can relax the muscles and come closer to that ideal physiologic rest position that we learned. So usually a good orthotic, and they're usually mandibular orthotics. They're not maxillary night guards. These are different than night guards because they have some anatomy and they guide the patient to go into a more relaxed position. They usually improve EMGs. They improve the patient's symptoms. Patients cannot chew with them, so they have to take them out and chew with their pathological occlusion. So let's say this patient's mandible is retracted by 5 millimeters. She has to chew and function there, which can put muscles in spasm. But then when she's swallowing without chewing, then she can come forward with this. So they have to kind of like go back and forth. They still work. They eliminate a lot of the symptoms because they eliminate pathological occlusion. And see how this appliance is taller on the left side compared to the right side. See that? Why did I design that appliance taller on the left side of the patient compared to the right side? Well, look at her bicuspid drop off. Look how her number 10 to 12 kind of like arches up, and there's more bicuspid drop off on that side. So when she's lost that height there, her mandible, which moves like a plane, can actually decompress and get and close deeper there, jam the a condyle to her ear on the left side and cause all sorts of problems down to her nose, to toes, not nose. So it will, you can see when I relaxed her muscles, her mandible actually decompressed, and then I was able to construct my orthotic to that position. So it's very important for the doctor to decide where the bite position needs to be. You cannot just send an upper jaw and a lower jaw to your lab and have them made and make an occlusal orthotic. They don't know where the orientation of that is. They'll just open it like that, but the patient's not opening like a snake. Patient's opening in an arc-shaped form. Their closure is different depending on their anatomy, the angle of the mandible, and everything. So it's really important for us as providers to use the patient as an articulator. It's a custom-made articulator. Have them relax their jaw to the most optimal position, and then build that orthotic to that position. So with my neuromuscular background, I measure muscle activity before and after to make sure that the muscles are in a good position, and we can dig deeper into that technology. It's been great to be able to have some data. So this type of appliances is what I used to start with, and that's why I use this for this patient. After this, if I want to do a full mouth reconstruction to this bite position with taller teeth on one side than the other to level this mandible, I had to switch to something more functional. So from this, I used to go to a fixed orthotic. Unfortunately, I couldn't find fixed orthotic photos for the same patient. So on this one, you can see that I'm on the bottom. We put the patient in a fixed orthotic. That's something that I learned at LBI. So what we did was to do a diagnostic wax up of where we wanted everything to meet. And then we would make a stent and use our temporary material and just deliver that almost like 14 temporary crowns on top of the teeth without shaving the teeth, without prepping. We're still in the orthotic phase to see how the patient is functioning. So from basically a deprogrammer from the previous slide, we go to a more functional appliance. So these are anatomical. Patients can chew with them. They're stuck to their mouth. They chew and function constantly in that optimal joint position and optimal muscle position. The only problem with them was that they're stuck to the teeth. So only I, as a dentist, could remove that. So if the patient moved, and usually another dentist doesn't want to take the responsibility of removing that. So they had to go to like a full mouth reconstruction under my care. And sometimes there was, if I trapped some air delivering that, in case I had a patient that had wanted to actually just do ortho, wanted to finish her case with ortho, and she ended up with 7 areas of decay. You can see that. So that's why I thought there should be a better way than just sticking these to the teeth. And if the treatment took longer, then the chance of decay would go up. And then after that, so after the orthotic, after the fixed orthotic, I would do a full mouth diagnostic wax up before my preps. So you can see I've used 2 appliances so far. I've spent some time on adjusting the appliance and determining a good functioning position for this patient. And then to that, I would go ahead and do a full arch diagnostic wax up so I could make my upper and lower temporaries. That was a lot of work. It was a lot of lab costs and a lot of chair time. And that's why I looked for a more simple solution to this complex problem. That's when I designed MyAligner. So MyAligner basically is prefabricated resin made usually from PMMA blocks that goes on the surface of the teeth, and it replaces that removable orthotic, the fixed orthotic, and my full mouth diagnostic wax up. So before I prep the teeth, I kind of like get and this patient, you can see there's an intraocclusal space. So that means that I've already determined by taking my CT scan, by taking my airway measurements, by looking at the EMGs, that this is a good relationship, orthopedic relationship between the upper and lower jaw. So we're doing a build, basically making the MyAligner on that to test drive the aesthetics for the patient, to test drive the occlusal relationship. I can even adjust these and And the reason we have it segmented is because we wanted to be able to just have a nice draw on each arch and make him really small. So in a nutshell, this is what myeliner orthotic is. And because it's an occlusal device, we were able to get clearance from FDA for migraine headaches and TMJ treatment. And then last year, we also submitted it as temporary dental restoration. So it can be cemented on as a temporary solution for the patient before you transition into a full mouth reconstruction or more complex case. So that makes it, because of the FDA clearance, it makes it billable to medical, especially if you don't have TMJ coverage. A lot of times it's covered by because of the migraine headache code. So this is kind of like in action. The story of this patient is that he had tooth 8 and 9 and 24, 25 restored because they were worn down and he wanted a prettier smile. And just like that patient, the gourmet dentist patient that I just shared, he was breaking the incisors on the lower and the upper. So very deep bite, bad occlusion there. So the general dentist went ahead and put a set of veneers there. Well, he cracked the first set of veneers. She, at her own expense and everything, she went ahead and removed those, replaced them with another set of veneers, and they broke again. So by the time he came to me, he had cracks on those upper veneers. And on the lower, he had, I think, one temporary. So they were planning to remake so there was no talk about a pathological occlusion. But that's the first thing that I saw in this patient. And when we did a sleep study, he had moderate sleep apnea. It's obvious. He was just so overclosed that his tongue had no room there. So the first appointment, after I did the comprehensive exam and took my diagnostic data, I went ahead and relaxed his jaw with the TENS machine, and that's the bite that I took. Based on that, now we've designed thousands of these. We'll come up with the most aesthetic design that these patients can wear as a temporary solution. You can see that's a pretty big gap on the left side, but that's because he was rotated all the way to this side. And you might wonder, you're saying, these crowns might be just too tall and start rocking the roots. No, they don't, because these patients are in an optimal functional position. So we see a lot of stability. So because his front teeth were already big, I didn't cover those with myeliner, but I needed to address his bicuspid drop-off on the top. So we went ahead and put the myeliner on laterals on all the way to the molars. And he had a lot of abfractions on the top. So you can see we didn't go into those abfractions. And I decided to temporarily cement the top myeliner and then kept the bottom one removable. So we have different designs. We call it bondable or removable, just depending on the treatment goals and the anatomy of the teeth. So in the next slide, now you can see, now he has been wearing my temporaries or my TMD splint for a few months. He's comfortable, airway is better. He says that he's dreaming, he can sleep better. So I'm using those basically as my prefabricated temporaries now. The nice thing about segmentation, excuse me. The nice thing about segmentation is that you can, this device is that you can keep your bite stable. So as I mentioned, you can use the different techniques with the diagnostic wax up and all of that, but this technique just made it so simple for me, and it's making it simple for other dentists. So you can just remove one segment, do the reconstruction there if you don't want the patient to sit there for 4 or 5 hours while you're prepping all the teeth, and then do the other segment a different appointment. We have doctors that have CEREC machine in their office. So if they have stabilized myeliner, the full arch with myeliner, they take one segment out, they start prepping the teeth, they scan it. While their CEREC machine is making those crowns, they go to the next segment and they just continue that and then can finish a reconstruction in one appointment. Imagine the production for the office on such a big cosmetic case in one day, and a cosmetic and rehab case in one day, and it's very fulfilling.
For the patient too. I bet you once they get the myoliner, they're already happy. You know, it's such an
Yes.
improvement just with the vertical, you know, the VDO opening up as well. It's like a mini facelift many times.
Yes, it's like yes, exactly, and that's exactly what happened to this patient. You can see she had those gaps in the bicuspids, so that's a patient that had upper expansion done with a removable device. So that wasn't even surgical, and
Mm.
she went from a severe sleep apnea to a very mild apnea because there was so much room made on the upper jaw, and the lower jaw was brought up forward too. So this patient had orthotropics, expansion, and had orthodontics. The teeth were aligned. But still, she had a lot of uneven wear and vertical dimension loss. There's so much that you can extrude these worn down teeth from the bone. You cannot do too much. So because she had already lost like at least a couple millimeters of enamel from top and bottom, uneven enamel loss, her TMD symptoms came back even after ortho and after airway was open. So there's another stage to the treatment now, and you can see we're not even covering her front teeth because they're nice and bulky. And for best aesthetic results, we can just keep the reconstruction to that. You can see how much her face changes, her marionette lines, just get bigger, filled in. Her jaw is not retracted as much. Her mentalis crease will soften. So it's it's a test drive of your case before you finalize the case. And one might say, oh, maybe does the patient go to phase two? Yes, they usually do. Who wants to deal with like 6 pieces of removable pieces in their mouth? If they know that they have the option, they might have to extend the treatment a little bit longer to be able to afford it. Cases like this can go anywhere from 60 to $100,000 in US. So they might have to phase it out, but myeliner at least will give them some stability and function. And patients would just have to remove it and clean it like a removable device. I call it a denture or partial denture for people with teeth because it's actually covering the
That,
occlusion too.
that helps. Well, this is also exciting. And I'm so excited that we have a course to teach doctors how to do this. And this was just such a great collaboration because the need is there. You know, airway patients tend to have the ground down teeth and they need the restoration. So do we want to segue at all just to kind of speak about the course a little bit? Because I know this is such like your baby in a way that I love. Or was
Yes.
there something else you wanted to show us clinically before we move
I
on?
just have
Yeah.
a few more slides. Other applications are in facial aesthetics. We have some doctors in New York. I know Dr. Gelb really likes this for facial aesthetics,
Mm-hmm.
myeliner, and you just brought it up. You can really get rid of that double chin, bring the jaw
Mm-hmm.
forward. How many times have you seen patients with like a really weird looking fillers? Trying to get that position. It's sometimes
Mm-hmm.
it's not about the soft tissue. It's about the whole jaw alignment. And when we bring their jaw forward, look at her tongue. This is not. It's if that photo is in the same day. You can see with her makeup and everything. But that's the tongue that's living right here, and you can
Mm-hmm.
test that if you suction your tongue to the roof of the mouth and hold it there. You can really lift this area. I think I look better than I did 10 years ago
Right,
because of
right. We
all
were
of
talking
that,
about that.
because I moved my tongue upstairs.
Mm-hmm.
That's what we
So
need to
sweet.
do.
I agree. It looks
Um,
great.
so, and also athletic performance. We have athletes that are using myeliner to just be able to do better muscle recruitment. So this is kind of in action. This is a patient with a deep bite. You can see narrow upper and lower jaw. He's already gotten some cosmetic work to mask the underlying problem, and you can see when the myeliner is placed on the posteriors that suffer from a big bicuspid drop off, then the jaw immediately comes forward, airway opens up, and we're not claiming that myeliner is an airway device. Uh, we like to do more studies and do before and after and maybe submit to FDA someday. But a lot of times patients report that they feel better. And we can use this foundation as one prior to ortho. How many times have you started ortho, a simple clear aligner case that turns into modifications, refinements over and over again. The teeth are just not, the teeth look perfect on your ClinCheck, but it doesn't translate like that in the mouth, even though all the aligners are fitting. So the aligners are fitting, but the jaw moved. So you need to take that jaw movement into consideration before you start your ortho. And we are doing some studies on these patients with some other colleagues. And now most of these airway dentists are actually taking that first step and adding an orthotic phase to their complex cases like this, especially if the mandible, if it's a class 2, they add an orthotic phase. They allow the body to adapt to it for about 3 months. They can do before and after sleep studies. They can see how the neck is adapting, and your myeliner will need adjustment for the mandible to move to its ideal position. And then you can decide in phase 2 ortho whether you can achieve that alignment by just moving teeth, or do you really need to remodel the maxilla and do more of an orthopedic similar to this. So this is what we were testing with aligners. This is a myoline patient. So if the patient really bites on their back teeth, she'll have that deep bite, but we are holding the teeth there and trying to just move the teeth into that position. So this is the future of orthodontics, when you're actually instead of retraction orthodontics, you're getting more expansion orthodontics and treating TMD at the same time.
We had a great AHS conversation with Dr. Michael Gelb and Dr. Ben Moralia and you on how they utilize this for their ortho treatment. So I encourage everyone to go to our YouTube channel to get the full conversation on that. That was really great to see how they use myoaligner in their hands as well.
Yeah, and I wanted to introduce one of our, to the top airway dentists in US, and this is how she used it, and I love it because I think 3 years down the road, she ended up ordering one segment of myeliner, so I knew that the patient was still wearing it. You can see this is an elderly patient. Dr. Merchant shared with me that she cannot sit through a long appointment. Obviously, this is a full mouth reconstruction case, and you can see this patient has not been ignoring her mouth. She's had crowns on every single tooth almost, but they're breaking at the gum line. So, and look at that tongue. Look how that tongue is suffering for space. So
Yep.
what you see is basically her, Dr. Merchant's treatment position. And we build a set of myoliners, upper and lower. And now these are PMMA, they're not the plastic. So you can add composite to them, you can retrofit them, you can cement them on temporarily. So 3 years, this patient has been in this position with myoliner. And the only reason I think she ordered a lower right segment is because she ended up root canaling and changing some crowns there. So they are lasting, even though they're not, a really dense zirconia material. Why? Because the patient is functioning in a physiologic position. Even you can even make a simple mat device for nighttime and save this patient from suffering from sleep apnea. Or cases like this, this is again another case of mine, mandibular retraction. You can see this patient already has 6 anterior veneers, but the jaw was in the wrong position. So I ended up doing a myoliner on the lower arch and actually doing some reconstruction, and she's doing really better. She made a comment to me. She said, "You did 14 crowns for me, or veneers, and you didn't have to adjust them as much as my dentist had to adjust my front 6 teeth. Why is that?" And that's because the dentist was trying to fit these restorations to a pathological bite. I established a physiologic bite, and patients receive that much easier. Their function is in the right position, so I didn't have to shave my crown so much. I have more slides, but I welcome conversation and see where you want to lead
I
this.
think that so we just have, this is going to be recorded so we can actually put this on our YouTube as well for better access. But let's talk about the next steps of how doctors can learn from you, and we're just so excited to have you. I'm just going to go ahead and share my screen here I'm so excited about this course because it's one of the solutions that we want to provide. So let me just do this to review. Review. Okay, yeah, I think we can see my screen. Let me just do presenter view. So yeah, I'm so thrilled that, Airway Health Solutions, we tried to provide all the solutions, and this was one of the missing pieces, was the prosthodontic mini residency. And we're so thrilled to have you on board to teach what you've learned, to gather from all of your, it's almost like you're a builder, a puzzle builder, and now you have the puzzle, the whole complete puzzle to share so everyone can do it themselves. Let's talk about this mini residency and what doctors should expect from taking it.
Yes, I'm super excited about it. It's one of the most comprehensive courses I've given, so I'm really glad that we're doing it in collaboration with you. It's going to be a 2 day of on-demand or online course, and followed by a 1 day of in-person. We are going to offer the in-person 4 times a year, and currently in our headquarters in Mile in the Northwest. So the next event will be March, and then the following one will be kind of like early summer. That's also a good time to come to Portland and enjoy the beautiful scenery. The 2 days of online is going to start next week. So we'll go live next Friday at 9 a.m. Eastern time, correct? And
Mhm.
what we're going to cover in the first day basically is the signs and symptoms to look for, how to perform a comprehensive exam, the candidates that you need to look for, and treatment plan presentation, consent forms, all the necessary things that you need. And by the end of that course, I'd like you to be able to identify the right candidates and go back to your office Monday morning. And among the 40 patients that you probably see the following week, we know that what's uh, um, or 30% of 40 is almost 12 patients that could be a candidate. So if you can narrow that down to like maybe one patient that you pick,
Yeah.
then you can start the orthotic therapy on them, the phase one, just put them in an orthotic. And then in the second course, we're going to dig more deeper into how to set up the patient, the right scans, diagnostic basically design of the myeliner. And we can talk about other orthotics. I practice the fixed orthotic and removable. I will mention those briefly too. So you don't have to use the myeliner to benefit from this course. It just gives you a lot of the tools, the necessary tools and knowledge and background to be able to recognize, inform your patients, and then perform the right treatment if you want. With the segmentation design of the myeliner, I basically narrow it down to quadrant dentistry because a lot of dentists, and they have the right to be fearful of it. They can lose the bite when they prep 28 teeth. And with the segmentation of design of the myeliner, you don't do that. So we'll teach you how to basically plan these cases right, and hopefully by the second course, you have identified the patient, and then we can go ahead and move on and get him set up after 3 months. I usually recommend you keep him in a orthotic for 3 months so you have time to come and do your hands-on course. Or we're going to actually try to use my meta glasses and do it
And live stream.
live stream. We'll see
Mhm.
how the hands-on goes, but whatever I see, you're going to see too.
Right.
So, and then I would, part of the course, you get a one-on-one coaching with me. I would be happy to answer any questions. And then if you decide to use my aligner for this technique and for in your full mouth reconstructions, then we have an onboarding program that we can empower your whole team. We can give you the tools and resources to easily implement this in your practice and expand your services.
Right. So for me, this is like the missing piece, and we're so thrilled to have you. And again, it will be available on live stream. And if they can't make the dates because this will be run live for the first 2 days, it is on demand as well. So you can sign up now. We are offering a 20% discount, which is really a nice savings. So you can go ahead and use that code AHSMM as in Maryam Motlagh 20. And you can join and get the introductory rate for such a great course that will really elevate your general dentist practice. So we're so thrilled. I'm over the moon to have you on faculty. And again, thank you for sharing all your knowledge with us. And I hope people take advantage of it.
Thank you. It was a
Good.
pleasure to be here with you today. And yeah, I'm looking forward to the course next week.
Me too. So we'll see you next week and come join us and you'll expand your knowledge and your comprehensive care and your patients will ultimately benefit from it. So thanks again and have a great weekend, everyone.
Thank you. Have a great
Yeah,
weekend and start identifying those patients Monday morning.
exactly. Exactly. New glasses, TMD glasses. Take care.
Okay,
Be
bye-bye.
well. Bye.